Sure. So, welcome everyone to our third episode of the webinar of hemodynamics, perfusion, and congestion. Today's topic, we have an expert, Dr. Casey Albin, who's an expert neurointensivist. I'm not going to go through her academic background, but I will focus on what matters to us, which is that she's a world-class educator. And what it's spectacular is her contribution to the MCRIT neurocritical care site. But if you go online and you read her contributions, you'll be enlightened on this fantastic topic, which is neurointensive care. Welcome, Dr. Albin, and thank you for joining us here.
It's like such a delight. This is like such a great thing to talk about, and I think that this can be such an intimidating topic, and so it's really going to be fun to sort of demystify what all of this means and how do we best optimize our neurocritically care, like our neurocritically ill patients.
Fantastic.
Wonderful. Yeah. Thanks so much for coming. You know what? Before we hop in, we do just want to say a quick thank you to our sponsor for HCP Rounds this season, which is Flowsonics Medical. If you don't know, they produced the first wireless wearable ultrasound patch that monitors the carotid and jugular vessels in the neck. The carotid artery can give you surrogates of stroke volume to assess for things like fluid responsiveness. And then the jugular the waveform can tell you things about congestion, which is actually one of the topics we're going to be exploring today, and congestive encephalopathy, and how venous congestion can actually contribute to abnormal or harmful hemodynamic milieu for the brain. And so thanks again to Flowsonics for sponsoring our season here. We really appreciate it. So I'm actually going to kick us off with cerebral autoregulation just at the very, very core level here. We've all heard this terminology here, that there's this cerebral perfusion pressure range in which our brain can tolerate. And cerebral perfusion pressure at a very kind of basic level is your MAP, or your mean arterial pressure, minus that intracranial pressure. And over a very wide range of cerebral perfusion pressures, we autoregulate. And what that means is that the pressure goes up, the pressure goes down. The actual blood flow in our brain stays fairly similar. But as that pressure starts getting lower and lower, we get into this realm of hypoperfusion and ischemia. But when the cerebral perfusion pressure gets too high, we can actually get hyperperfusion, hyperemia, and edema. And so we want our brain to stay in this kind of like sweet spot. But this is a really simplified version. Certainly, this is how I think about cerebral perfusion pressure and cerebral autoregulation. But that's why we have Dr. Albin here to take us maybe to the next level here. So maybe just starting off, Dr. Albin, how do you conceptualize cerebral autoregulation and cerebral perfusion pressure?
Yeah. So I think that this is really actually one of the most complicated topics to understand in neurocritical care when we're thinking about neuroresuscitation. Because it's so dynamically intertwined, and the normal physiology is very different than pathologic states. And so I think that that's really one of the things that's important to know about. And so a couple of slides that just try to highlight this. So a key principle, as you said, is that cerebral autoregulation is dynamically intertwined with what the MAP and the ICP is. And that's because, like you said, we've all memorized that formula. And while it is, I think, a vast oversimplification for the sickest patients, in general, we can kind of apply that, how much perfusion pressure you have is directly how much pressure is going into the brain and how much resistance to that pressure is. And that resistance is given by the intracranial pressure, right? And so if your normal intracranial pressure is somewhere less than like 15 millimeters of mercury, right? And it's a little bit more if you're lying down, a little bit less if you're standing up, but it's dynamically in a range that your body can handle. Now, MAPs are widely different between patients, right? We all know the patient who is chronically hypertensive is very different than the patient who, is young, healthy, has a blood pressure of 104/64, is very different than the patient who has a routine blood pressure of 170/105. And so I think we do have to, even at the most basic level, think about who is the patient in front of us and where does their MAP typically live, because they've probably regulated towards either being adapted to a cerebral perfusion pressure that is lower if they live at a chronically sort of low or normal MAP. And they're dependent, and I think this is the more important patient population, that's older, chronically hypertensive, saying that they can tolerate a cerebral perfusion pressure of 50 is going to be wildly not appropriate for them, right? Like they are used to having, a map of 105, 110. And if you drop them to, much less than that, they are going to really struggle to perfuse, right? So again, even when we think about the most simple relationship between cerebral perfusion pressure and blood flow, we know that there's personalization in this, and not everyone is the same. All right, so we're talking about the pressure, right? And so the pressure is what creates a driving force of fluid into the brain. But we actually really just care about the blood flow, because it's the blood flow that actually is going to deliver the oxygenation to the tissue. And so when we go back to, Ross, if you go back to that first slide you show, the x-axis is your perfusion pressure. And yeah, perfect right here is your cerebral perfusion pressure, and your cerebral blood flow is what we're holding constant, because that's actually really what matters, right? We want the oxygen to be delivered to the tissue. And so what's interesting is, cerebral perfusion pressure really relies on MAP and ICP, but we really care about the blood flow. And so how does your brain do this, right? So you have cerebral vascular resistance. So that's that SVR term, right? And we know that is a ATP dependent process where you are auto-regulating, right? And so perfect, I love that. So as you are, creeping up in your cerebral perfusion pressure, your brain is well adapted to say that's going to be too much blood flow, right? And you are going to vasoconstrict. So you see at the right of that little nice little outline that we have, the little small vessel on the right side, right? So your cerebral perfusion pressure creeps up, and your brain says, too much blood flow. We're going to vascularly regulate, and we're going to vasoconstrict. Versus on the flip side, you hit a lower cerebral perfusion pressure, and your brain has the ability to vasodilate, so that you're still at that lower pressure, still unable to get that same amount of cerebral blood flow. And that is the sort of core normal thing that we are worried about, which I think you should all be thinking, well, like, it sounds like since all of this depends on cerebral perfusion pressure, it means that we have to know the ICP, right? I feel like that's one of the things that's unique about this, is that if we're doing cerebral autoregulation and we want to do it with the most precise data, we actually kind of have to know what the patient's ICP is, right? And so there are a couple ways you can get this, but to get a real number, you really actually need invasive measurements, which are mostly given by external ventricular drains, or EVD. Bolts are another way to do this. It's a parenchymal probe. But those are sort of your two options. And what's interesting about this physiologic data that we get when we're doing ICP monitoring, we actually get not only a number, but waveforms. And I think that that's sort of the undersung hero of ICP monitoring, is the data that you get from actually just looking at the waveform to understand the patient's brain compliance. So I think when we're getting ICP numbers, sure, we're going to plug our ICP number into the formula and say, their ICP's kind of been on the high side. Like they're clearly a little bit more on the higher ICPs. We want to allow them to have a higher MAP to compensate for that. But we're also going to look at the ICP waveform data and say, is this patient having a normal P1 is high, P2 is lower, P3 is even lower than that? Or do they have poor compliance? In which case, P1, which is your systolic pulsation, causes reverberation of tension throughout the CSF, causes an elevation in pressure, which is that elevated P2, and then you have closing of the dichrotic notch, which is P3. So that actually gives you a lot of data about the compliance in the brain. If you see that sort of ugly, what I describe to students as like the waveforms giving you the middle finger, then you know the brain is really at the sort of the max of its compliance is really diminished. So that's the patient where if you lay them flat for a scan or you need to do a tracheostomy or some other procedure, they're at really high risk of getting into an ICP crisis, which you have to think ahead. Like, oh, if they're going to be in an ICP crisis, what can I do to optimize their cerebral perfusion pressure? How can I find some other way to lower their ICP so that I create more room for if I have to lay them flat, they have to go to scan or whatever it is. And so I think a lot of it really starts when you're thinking about being mindful of cerebral perfusion, is being mindful of patients' ICPs. And it's not just the number, but what their compliance looks like. So I'll pause there and
yeah, that's incredible. That's incredible. I've never heard such a eloquent kind of summary of cerebral perfusion pressure. One question that really comes to mind is, for example, in sepsis, we talk about a concept of hemodynamic coherence, where macrovascular or macrohemodynamic changes in flow and pressure may or may not correlate with actual changes at the tissue level. Does the same principle apply to the brain? Could you have a cerebral perfusion pressure of 50 or 60 that has really good perfusion, but then also the same cerebral perfusion pressure that has really bad perfusion, unrelated to any kind of macrohemodynamic, but more related to the kind of cerebral microvasculature?
Yeah, I think this is one of the things that we don't know so well. I think that this is where sort of advanced neurologic monitoring with ECG, where we're thinking more about the sort of less about the structural phenomenon of like the vascular appearance, with like something like a CTT, you get a cerebral perfusion, right? With something like TCDs, you get a signature of what's happening with the blood flow velocity. But I think at some point, we just want to know, like, is the brain seeing enough oxygen to do its structural or to do its function? And so then we get into sort of like functional monitor, which is really more like EEG monitor. So if you were to see someone who has a cerebral perfusion pressure of 50 and they're still in an alpha rhythm, they have no epileptiform discharges, they don't have signs of slowing, that probably tells you that the brain is actually seeing the oxygen that it needs to do. Similarly, you can sort of get a sense of how the brain is doing from absorbing oxygenation with the jugular vein oximetry, right? So I think of jugular vein oximetry in a little bit of a way of like an SpO2, although it's a little bit different in the way that the numbers work. But that's another way where we can sort of say, is the brain absorbing so much oxygen that it's clearly not getting enough? Like we're still not getting enough perfusion, because when we pass a jugular oximetry number, we see 50%, meaning 50% oxygen is being abstracted. The brain is asking for more and more and more, or we're seeing hyperemia or maybe even dead tissue when we're getting a lot of oxygen back, and like clearly the brain is not using what it's getting back. So I think there are ways that we can use sort of advanced neuromonitoring to better understand the structural and then the hemodynamic, like the oxygen consumption of the brain, to get a sense of whether or not the brain is actually, the tissue is seeing the oxygen that it needs, if that makes sense.
Yeah, it totally makes sense. Thank you for that. Now, before we move on to talk a little bit more about how we actually monitor ICP both invasively and non-invasively, is there anything kind of new coming out in the field of cerebral perfusion pressure, autoregulation, anything kind of exciting in that realm?
Yeah, absolutely. So I think I'll have you bring up one of the slides that says pathologic states, because this is the one before that, actually. Because what's interesting about the brain and cerebral perfusion pressure is that in normal states, with no pathology, the brain is able to create its own vascular regulation to basically keep cerebral blood flow stable, right? Like that's what we talked about. It is so different in the injured brain. The injured brain has had neurologic injury. It does not have ATP. It might be dying. It might be surrounding blood. It just is not behaving normal. And then we get into this very bad state of that green curve that Ross is highlighting, where we have this very scary linear dependence of every time cerebral perfusion pressure goes up, the brain cannot vascularly regulate, and the cerebral blood flow goes up, right? And remember, cerebral blood flow, the more we have in the brain, the more likely we are to get into a state of an ICP issue, right? Because the reason we care so much about ICP is because the brain is a fixed box, right? The skull only lets so much in. You can only have blood, CSF, and brain. And if you put too much blood in there, you are going to start to have a pressure crisis. And that is a really horrible spiral to get in, right? Because now you have a high ICP and you're sort of like, oh no, like now I need to support the brain. I need to give more blood flow, right? Oh my gosh, there's so much downstream resistance. If we don't give more cerebral perfusion pressure, we're not going to be able to oxygenate the brain, right? And then you get into this sort of spiral thinking that the brain needs more blood flow when really you have a hyperemic tissue that's in an ICP crisis because it's seeing too much blood flow. And I think this took a really long time for me to like sort of sit and think about. But that is like that's what's interesting about brain physiology is that when you get into this pathologic state, you can get into a place where you're in an ICP crisis because of hyperemia, and actually giving more cerebral perfusion is going to cause more problems.
Can you check? Can you check that actually at the bedside by giving a map challenge? Say the map is 75. Could you drive it to 95? And if your ICP increases by a certain amount, that would suggest that you've lost this autoregulation?
Yes. So you can absolutely do that. And I think that that's one of the things that's really fascinating to do at the bedside is to give people a little bit of a challenge. I don't tend to do 20 points of a map, but like we'll put them up 10 points, right? Say their map is 75, go to 85. And if you watch that their ICP is just going up, you say, they are in a pathologic state where we are just having a spiral and we need to actually, they were happier at a lower map. So even if it feels counterintuitive and you're saying, oh, well, like, their ICP is 20 and we're letting their map be 75, that's going to put them in a CPP of 55. That's sort of below our typical threshold. Sometimes they behave better at that point. And again, this is thinking a little bit more about the personalization of the patient in front of you and how are they responding to the blood flow. You can also do this while watching them on TCD and see, that at higher blood pressures, do they start to have higher pulsatility indexes and lose diastolic perfusion because their ICP is going up, which is really cool. If you look at the next slide down, basically an algorithm to do this is what's using CPP optimization. So this is the new hot take, and I really, really wish we had this, but we don't. It is only in some centers, but I do think that this is a really neat way that takes an index, which is a Pearson coefficient. It's taking that data from the arterial blood pressure and the ICP, and it's continually measuring them and integrating them to say, how does, as the map increases, is the ICP staying the same? Is it going up? Is it going down? What is the beat to beat variation between your map and your ICP? And it integrates that data to give you a perfusion pressure that is optimal for the patient, which I think is super cool. And we know from the Columbia group that this actually, those people who stay in their optimized CPP goal, they have better brain oximetry. So they are less likely to get in a place where the tissue is ischemic or not getting the oxygen it requires. There is a signal that maybe it even has better outcomes. And so I think that this is really cool and a way to, at the bedside, integrate that data between your blood pressure, between your ICP, to say, what is the patient's unique, personalized, optimized CPP, so that we're actually spending time in that optimized. And that could be, a CPP of 75, it could be 100, it could be 50, based on the patient's long-standing, relationship between blood pressure and ICP.
Yeah. Thank you for that.
That's actually that's fantastic, Casey. Just to make it clear for the audience and maybe even for me, how does this CPP optimization actually work? Is it an invasive oxygen probe, and then you kind of probe the blood pressure and the intracranial pressure to try to find the place where the brain has the most oxygen saturation, or how's this titrated? How do you
does it work?
Optimal perfusion pressure?
Yes. So it's integrated. It is hooked up to the ICP data and getting the mean arterial pressure. So it's hooked up to the A line and it's hooked up to the ICP monitor. So it's getting those two parameters, and it's basically determining the PRX, which is the moving Pearson's correlation between the ICP and the arterial blood pressure. So it's looking at the ART line and the ICP and creating sort of this moving coefficient correlation between how does one respond, how does the ICP respond to the MAP.
Got it. So that means the oxygen is actually the outcome, right? So by titrating your ICP and your MAP to an optimal correlation position, you try to find the best tissue oxygenation. But that probably was the outcome of these studies.
Yes, absolutely. So yes, they had a LICOC monitor, which is a parenchymal probe. And they would look when the patient was outside of their cerebral optimization curve, like when they were outside of what the device had said, this is their optimal range, the times out of it, how did that correlate with the oxygenation of the brain on the LICOC monitor device they were using? Basically, what it was the oxygen saturation at that point versus when the patient was in their optimized, CPP range, how did the O2, the brain tissue oxygenation work at that point? So that was basically two devices looking at we think in theory that being in your optimized cerebral perfusion error is really good for you, but is it? And it turns out that yes, it is, that your body is seeing a better amount of oxygenation when you spend time in your optimized CPP range.
Well, that's fascinating. And I think you've
really
established
cool.
that monitoring cerebral perfusion pressure is of extreme importance in this patient. And of course, not every center has an intracranial invasive monitor that we can use for minute-to-minute variations on intracranial pressure. But I know there's some other technologies that allow us to monitor or at least get a glimpse of increased intracranial pressure non-invasively. I'm particularly interested, of course, in transcranial Doppler, but I know there's also other methods such as EEG. For transcranial Doppler, I've always wondered, since I do a lot of Doppler of other organs, and I know that arterial waveforms, arterial signals, are not only dependent on the compliance of the organ that you're intubating, but how do you reconcile the pulsatility index that you see in the transcranial Doppler with systemic hemodynamics? I mean, we know the pulsatility index of any blood vessel can be increased by increased pulse pressure. This is a stiff vascular tree. Maybe it can also be increased in patients with severe aortic regurgitation, but just because of the aortic regurgitation, you can have very low diastolic blood flow. And of course, you can have a very low pulsatility index in some conditions, such as VA ECMO, where there's very little work being done by the heart and the pulsations are really low. And then how do you reconcile this external macro hemodynamic parameters that could alter something that you're trying to associate with intracranial pressure? So maybe if you want to just discuss briefly about transcranial Doppler, I would appreciate it a lot.
Those are so many great questions. There's like a lot to parse through there. I love TCDs too. I think TCDs give us a huge insight into patient physiology, right? Like this is really, we care about blood flow. And with TCDs, we're actually looking at the blood flow, which I think is super important. So this is an example of just a normal MCA TCD, right? And it's going to look like kind of like your A-line tracing, right? You see a nice systolic uptake, and then you see diastolic decay. And you see, at the base, so the X interval here is time, and the Y axis is blood flow. And what you're seeing is that we have good blood flow in diastole, right? And so this is we talk about that diastolic flow by the pulsatility index versus the next one. Let's say show sort of the next example of someone who has very low diastolic flow, has that very sharp, spiky appearance of their TCDs, where they have a systolic spike up and then they drastically decline. And I love what you said, like this can be due to a lot of different things, right? So the patient with aortic regurgitation can look like this because they have a lot of blood flow during systole and then a lot declines back during diastole. I've seen a patient who had a cocaine vasculopathy who actually had a signature like this from the beginning, just based on like the stiffness of the arteries. I had never seen that before. But I think what made me clue into like, hey, this is actually the patient's chronic cocaine use was you pair this with your neurologic exam. So I think a lot of it is getting to know, like, does the patient look like they're in an ICP crisis? Does the patient look like they might have perfusion dependence, right? So I got this, like, this is not this patient's specific waveforms, but basically they looked exactly the same. I got them back and I was like, this patient is sitting up awake and talking to me. And the first thing I did was I pulled up their echo and I was like, well, surely they just have aortic regurgitation. And they don't. And so then I'm like, well, what else could it be? Like the patient does not look like they're in an ICP crisis. Do they have downstream resistance? Like, is there some sort of like vascular resistance that's in the small or medium arteries, right? So downstream resistance. And it turns out the patient was a chronic cocaine user, and it's well described that this stiffens the like medium-sized vessels. PCDs are not measuring your medium-sized vessels. They are measuring your large vessels in the brain, MCA. So that patient had this signature because of downstream resistance from chronically stiffened arterioles. And so again, it's a little bit thinking about like, what does the patient look like in front of me? Does that match? And then having a baseline is so important, right? So the patient who comes in and has a very normal looking PCDs, and then 2 days later, they have their infarct is swelling, they're sleepier, and now they look like they have very high pulsatility index. Well, we know before they looked normal and now they don't. So PCDs really are nice because you can get them, as often as you need. And you have a sense of what the patient's baseline is and how they're evolving. And then finally, the last thing I'll mention is that we can specifically look at how the brain's arteries are responding outside of the context of the patient's global hemodynamics by looking at a ratio called the Lindegaard ratio. So the Lindegaard ratio basically looks at how fast things are going in the the middle cerebral artery versus the carotid artery, right? So we know that patients might have, like, say patients get more anemic. They may have faster flow, right? That's one of the things that we worry about for patients with vasospasm is how fast is the blood flowing? Well, the anemic patient's going to have faster flow, but the anemic patient should have faster flow both intracranially and extracranially. Exactly. So if you look and you look and say, the patient's blood flow is fast everywhere, their Lindegaard ratio is still 2 or less than 3, then it's probably a global problem. Whereas a Lindegaard ratio greater than 3 is more specific for intracranial vasospasm. So again, that's not looking necessarily at pulsatility, but it's a way that we normalize the speed of flow to the brain versus the neck vessels. So I would say the 3 takeaway points there are: A, get a baseline; B, look at what the patient's looking at in front of you. If they don't look like they have a reason to have a high pulsatility index because they don't have a high, they have no reason to have a high ICP, think a little further about it. And then B, if you're looking really for faster flow, and in which case you're monitoring vasospasm, you can look at that between the way that the flow is behaving extracranially and intracranially.
That's brilliant. I do have a quick follow-up. Is this
Yeah.
something that needs to be done with kind of formal TCDs done by a tech? I noticed these kind of beautiful displays. Or is this something that POCUS or point of care ultrasound TCDs can accomplish? And if you are using point of care ultrasound TCDs, do you do them bilaterally or is unilateral sufficient in your mind for ICP estimation, not for vasospasm?
Yeah. So we are so spoiled because we have techs that can do these and they do them day by day. And we can call them and they'll come back and they'll do them multiple times a day and they'll sit with us at the bedside if we want to give like, acetazolamide or something and challenge the patient sort of pH or like hyperventilate them. We're really very, very grateful to our techs. So I personally do not do my own point of care ultrasound. However, my colleague Erica Sigmund is like an ultrasound master and she does these at the bedside. And so it is hard. You have to learn how to do them, but you can do them on an ultrasound. You have to set the preset so that you're looking at the right thing. But she does them at the bedside. I would get both, just to confirm that you actually are seeing, what you're seeing is real. It does take some practice. It does take some time to get good at. But for people who don't have a tech, it is possible to do this point of care.
That is actually fantastic that we can. I have many intensivist friends who love to do transcranial Doppler on the bedside, and we don't have the tech, so we have to learn how to do it. And
you can.
Yeah. I was just going to say that I think your idea of normalizing the velocity of blood flow from the MCA to the carotid artery is pretty similar to what we do. And I mean, I'm a nephrologist, and we often look at the renal resistive index, which is almost the same as a pulsatility index. And when it's very high, I usually have the question, is this a renal specific problem or is this a systemic hemodynamic problem? And I usually normalize this pulsatility index from the kidneys using the spleen or either the hepatic artery resistive index. And then if both are high, I would say, okay, this is probably a systemic condition. And if only the renal is high, this is usually acute tubular necrosis or some specific intrinsic kidney disease. I think that's the way it should be done.
Yeah, absolutely. I mean, it's all about like, how does this fit into the patient's global cerebral or global perfusion?
Yeah. So maybe besides transcranial Doppler, I know you're very keen on other monitoring tools that are also non-invasive. And one I would like to know more about is the the EEG monitoring tool for intracranial pressure. Maybe you can guide us more through it.
That's a great question. So EEG is not necessarily monitoring intracranial pressure. It is much better at monitoring the functional downstream of the effects of ischemia. So this is I don't think there's a slide. The last slide. Okay, go to the last slide of the slide deck.
Oops. Oh, just let me share. I went too fast. I'm sorry.
No worries. So really, when we're looking at EEG and multimodal monitoring, it can be used for so much more than just seizure detection. And so I really love when we've been understaffed recently, so we haven't had the readers to do this, but we know that when blood flow decreases, there is a signal of you go from faster frequencies that are normal to slower frequencies, which show that blood flow is not normal, right? And that is described as the change between alpha waves, which are normal, to delta waves, which are very slow waves. And so we can describe patients' physiology by this alpha delta ratio. And again, you have to know the patient's baseline. You have to take it into consideration of what's going on. But this is a really cool way to monitor for vasospasm. So for patients who have delayed cerebral or have risk for delayed cerebral ischemia, we can see if they have a declining, what we call the alpha delta ratio, meaning you see more and more delta, which is at the denominator of this ratio, which means it's a lower number in general. So here you can see this is a really cool case. This is how we do ischemic monitoring. The patient, basically in all fields that we're looking at, their ADR is basically at the zero base. They are all delta, like nothing good is happening. And we know that that is a very concerning finding for the patient being lacking the cerebral blood flow that they need. And so one of the things that, sort of new and has really gained traction and interest over the last 5 years is using milrinone as a way to treat patients at risk for delayed cerebral ischemia. So what you can see is that purple line is when we started the milrinone infusion. And within 30 minutes, you can actually see that there's an uptick in alpha activity and the patient's starting to get better. And you can also see in the two sort of block graphs below that, you see that the solid blue at the bottom and the red at the very, very bottom. Before we started milrinone, there was basically no variability. This is what's called the relative alpha variability, which means that the patient has no change. Their EEG always looks the same. That is not a good thing. Then we start milrinone and the patient keeps having state changes. They're awake and then they go to sleep and then they're looking around and now they have more alpha. So their relative alpha variability increased, and that's a good thing. And so I think this is a really powerful way for us to downstream monitor the functional outcome of things like cerebral perfusion pressure, right? And so this can be done in real time at the bedside continuously, which to me makes continuous EEG monitoring and quantitative analysis of EEG monitoring one of the most fascinating ways that we can actually long-term monitor patients' brains.
It's kind of like the cap refill of the brain.
Yeah, it totally is. It's amazing.
That is fantastic. Yes.
And so, the cap refill of the brain is honestly the neurologic exam. That's our quick and dirty, are you awake or not awake? Yeah. But I think one of the things that we really, I was just talking to y'all's group about this is there is a danger in doing the neurologic exam every hour, every 2 hours. There is a real problem with waking people up all the time. And we have got to get better at monitoring the brain without just sternal rubbing patients every hour to see whether or not they wake up.
Yeah, that makes a lot of sense. And, talking about monitoring the brain and doing neurological exams, we've talked a lot about hemodynamics and how hemodynamics affect brain perfusion. But I think one subject that we're very interested in that's usually left aside is that we're not only worried about mean arterial pressure and cerebral blood flow, but also venous pressure. And we know that cerebral veins drain into the right atrium. And when you have severe right ventricular dysfunction, you can have organ congestion. And we know this because Ross and I are nerds of venous congestion. We love to study the subject. And this is our subject most dear to our heart. And we're very, we study a lot patients with congestive hepatopathy and congestive nephropathy. But recently, we've come to learn that patients with severe venous congestion can also have delirium and altered mental status. And this has been coined the term congestive encephalopathy. And I don't know, what are your takes on this subject? Does this really exist? Is this mediated by increased cerebral venous pressure, or do we need to do more research to really understand this condition better?
This is so cool. I have not thought about this until y'all showed me that paper. This is not something that I spend a lot of my time thinking about, but this is so important, right? And I the more I was thinking about it, the more I was this physiologically really makes sense, because we know if you have an occlusion of the venous sinuses, you definitely get this, it starts small, but this global cerebral edema, right? And why would this be important? And I was trying to think about what we know about delirium, which is not a whole lot. But one of the things that's been really actually more recently studied, and I think this kind of all came together in my mind as I was thinking about this afternoon, is that one of the things that we talked to your group about at Western University is this new idea of lymphatic system and the way that the brain cleanses itself and delirium. And so we talked a lot about, this is kind of a new sort of avant-garde topic in neurology. But we have found that there is the way that the brain is clearing itself is through this conductive spread of CSF which causes, sorry, not conductive, convective, which causes convective solute drag through the brain parenchyma. And where does all of that convective drag end up? With all of the like waste products of the brain, specifically some of these detrimental plaques and tangles and sort of proteins like tau and alpha-synuclein. Like, where do all of those end up? They end up going to the perivenous system to be drained in the internal jugular vein, right? And so it totally actually, it clicked to me today that if we are having poor venous drainage because of high, sort of global congestion, then it totally makes sense to me that we're not doing a good enough job recycling some of these pathologic solutes and structures and proteins in the brain. And so maybe go up a couple slides to where, or down a couple slides so we actually have a picture of the video of the way that the lymphatic system works. So play the little video here, because I think that this is really cool. As I was thinking about this today, I was like, obviously it makes sense to me that if we have poor venous drainage because of high, global right atrial pressure, there's just, venous congestion, where all of this solute drag ends up is to the venous system. And if that's not occurring and we're not able, you can see all these little molecules that are like the trash, they're little orange molecules. If we are not having that convective solute drag, and the place where recycling all of this is impeded, then it does make sense to me that this is one of the ways that the body is all intertwined, right? And so I don't know if that is the root explanation, but I think one of the things that I've learned as a neurointensivist is the brain really cares about homeostasis. Like, the brain wants to be at normal physiology. And the more that you disrupt normal physiology by being volume overloaded, by having global congestion, the less the brain is able to do its normal brain function. And so I think this is one of the reasons why, because we know that patients who are not, let me say it softer, we speculate because the lymphatic system is more active when you are sleeping, that patients who are sleep deprived end up delirious. And that's one of probably many reasons that you end up delirious, but there's sort of new emerging research that depriving the lymphatic system of its ability to work by sleep deprivation really causes delirium. I don't think we know if depriving the lymphatic system of its ability to flush toxins because of venous congestion causes delirium. But I love that paper that's linking congestion and to encephalopathy and delirium, right? I think that that's a really amazing, hypothesis to test and to more rigorously evaluate. And I think it'd be really interesting to know sort of more the signature of what the various patients TCDs look like. Was there downstream resistance to flow? Are you getting poor perfusion because of venous congestion? I think there's really a lot of ways that we could investigate, what is the mechanism by which congestion impedes normal brain function. But I do think that that is really strongly suggestive. There is something about congestion that does, I think, put the brain off of its normal homeostasis, whether that's through lymphatic system, whether that's through high pulsatility and poor forward flow. I don't think we know. But I think that this is all to say that we do need to prevent congestion, and we do need to sort of minimize, volume overload for patients.
Yeah, beautifully said. And we'll make sure to link the paper from Deneau in the show notes for the episode and on hcprounds.com, which is our website, just so that everyone can read that. I will say that there's some interesting kind of literature showing that positional changes, for example, head down, can result in cerebral desaturation, potentially related to venous congestion, and also that congestive encephalopathies associated with cerebral desaturations. And so actually at Western, Dr. Slesser, Dr. Besmagi, and I are looking at the association between systemic markers of venous congestion and cognitive outcomes following critical illness, with the hypothesis that congestion is actually resulting in potentially delirium and longer-term cognitive dysfunction for ICU survivors. So it's something near and dear to our heart. So thank you so much. The glymphatic system, you know what? I love the name of it. I love the system. We're going to find a way to make lymphatics great again, so to speak. I guess with maybe the last question here, or sort of the last topic we can explore, and you already mentioned this a little bit when you mentioned EEG in subarachnoid hemorrhage, but there's a lot of discussion in subarachnoid hemorrhage about vasospasm. But now there's this new term, delayed cerebral ischemia, or DCI. In your mind, what's the difference? And maybe are the two correlated? Do they always correlate? Are there times that they don't correlate? How do you conceptualize these concepts?
Yes, this is like so important. And I think this is one of my soapboxes that I stand on. When we round and people say vasospasm and you say like, oh, like, well, like, what are their philosophies? And they're like, oh, well, I mean, they're not really like, they're not in spasm, but they're having like their neurologic changes. And you're like, oh, so they're different. And they are different, right? So what we care about after subarachnoid hemorrhage is delayed cerebral ischemia. We know that after subarachnoid hemorrhage, there is a very complex cascade of events that puts patients at risk for having ischemic infarcts within the first usually 21 days, classically. And it used to be that we thought that that was all because of vasospasm, that the arteries would shrink down, which they do sometimes, and then the patient would be deprived of blood flow, and then they would go on to have an ischemic event, and that was that. And it is so much more complicated than that. There are absolutely patients that have rip-roaring vasospasm who are awake and talking to you and neurologically totally intact. And it makes everyone very nervous because their arteries look like wisp, and you're like, oh my God, how are they perfusing? But they are getting plenty of blood to their tissues and they are neurologically totally fine. And they are living their life and they're like, why do you keep assessing me every 3 seconds? Like, I'm totally cool. And on the flip side, there are patients who, when we look at their TCDs, and if they get a CTA, like they have very minimal vasospasm. Like there's not really a lot. And then we see them and they are like neurologically not intact. And it's not delirium. It's not hydrocephalus. It's not seizures. I mean, there's so many reasons subarachnoid hemorrhage patients look bad. And we MRI them and they've had strokes. And so I think it all goes to say is that I think of vasospasm as a biomarker. Certainly the patients who develop vasospasm might be at risk and they might be at high risk of DCI, but DCI can develop independent. And that's because of like, if there's inflammation that happens, there's delayed or spreading depolarization or cortical spreading depolarization that can sort of upend the normal way that the microcirculation is processing and getting oxygen to the brain. Sort of like mini seizures that sort of end up potentially depriving the brain, those cells of oxygen. And there's cytokine releases that happen that make the tissues unable to process the oxygen, even if it's getting to it. And so I think it is so much more than just the artery spasm. And I think we see that day in and day out. And that's why I think that EEG is such a powerful tool, because you're looking at the functional outcome, right? You're looking at how the neurons are behaving, not the blood flow. I think you need both. You need to see, is the blood flow actually getting there? Do we have enough? Are we at risk? It's a great biomarker. But I think we also mostly care about the functional outcome, which you can better see with the EEG monitoring.
Wonderful.
Or the neurologic exam.
Now, a question. So if you had a patient with DCI, they have a bad neurologic exam, you've ruled out hydrocephalus, you've ruled out seizures, but radiographically they have minimal to no vasospasm. Would you still consider a trial of milrinone or some other vasodilator? And then what would you monitor to look for the response of that apart from clinical exam?
Yeah, that's a great question. So the way, and I will say that I don't have evidence to really show you that this is the the way this is what's actually happening. But my anecdotal experience is that milrinone is great for this microcirculation dysfunction. That there's something about milrinone that, because it's like, it's working in vasodilation, but through a different mechanism than sort of our calcium channel blockers. There's something that maybe it's the inotropic effect of it, that it's increasing global cerebral perfusion in a different way. I find that it really is helpful for those patients that are not having a ton of large vessel vasospasm, but we still think are having delayed cerebral ischemia. So like the patient that we talked about, where you start milrinone and you see, their alpha ratio just improves so dramatically afterwards. So I find that milrinone is my go-to if I am concerned sort of for the microvascular dysfunction. Versus, I love intrathecal nicardipine for these patients that have large vessel vasospasm, where it is functionally causing problems for them. That as a calcium channel blocker seems to work fantastic. Like, we know you give someone intrathecal nicardipine, it will relax their blood vessels at the large macro circulation level. Like, our group has data, so much experience. Like, not everyone, but a lot of patients are very sensitive to that. So I will choose intrathecal nicardipine if it's a sort of large vessel vasospasm issue, and I will choose milrinone if I don't see a lot of large vessel vasospasm, but I think the patient still has DCI.
I mean, and that's just beautiful. And I think that really goes back to one of the themes we talk a lot about on HCP rounds, which is the importance of connecting the macro circulation with the microcirculation. Looking at either in isolation is insufficient, and really it's only through tying them together and thinking about how they interplay, which largely we don't know and we don't fully understand. But I think that's really the frontier of hemodynamic resuscitation, phenotyped resuscitation, and how we can ultimately improve organ level perfusion and reduce these secondary insults in so many disease processes. So thank you so much, Dr. Albin. We're getting to the end here. Maybe I'll just open up for any final remarks, but it's been such a pleasure having you on and learning from you.
This is so great. This is like truly like the highlight of my day. And like, I love getting to talk about this. And for people who are thinking deeply about this, because I think sometimes we as neurointensivists get tunnel vision on like one organ. And I love that we have to think about the global big picture here, and to think about how we can help patients in other ICUs end up with better brain health, which, is crucially important.